We are going to move on to a presentation by Christian Dohring, who's a second-year medical student at the University of Rochester Medical Center in Rochester, New York. He's going to be speaking about a reappraisal of CT angiography derived duplex ultrasound velocity criteria with a comparison to digital subtraction angiography in patients with carotid artery stenosis. Take it away.
My name is Christian Dohring. I am a second-year medical student at the University of Rochester, and I will be presenting a reappraisal of CT angiography derived duplex ultrasound velocity criteria with a comparison to digital subtraction angiography in patients with carotid artery stenosis. Firstly, as a disclosure, there are no financial interests or affiliations concerning the material discussed in this presentation. As a quick background, the prevalence of stroke and its association with carotid artery stenosis is well known. Carotid artery revascularization has been shown to reduce the risk of stroke in symptomatic and asymptomatic individuals with carotid artery stenosis. The ability to assess the severity of stenosis and identify patients who could benefit from surgery makes imaging of the utmost importance. Carotid duplex ultrasonography is the imaging modality of choice for screening the asymptomatic population at risk for stenosis, based on its relatively low cost, lack of radiation exposure, avoidance of intravenous contrast, and its high sensitivity and specificity. Traditionally, angiography has been considered the gold standard in the analysis of carotid artery stenosis. In practice, its use is limited due to its need for additional resources, increased cost, and risk of stroke. Recently, there has been a shift towards using CTA as a new gold standard over angiography due to its less invasive nature, ability to obtain multiplanar views, and better visualize plaque morphology. CTA is also a more standardized imaging approach, while DSA is often operator dependent. The vast majority of ultrasound velocity criteria for estimating carotid artery stenosis have been derived from angiography measurements. In recent years, a few CTA-derived ultrasound velocity criteria have been published, including one from our institution in 2014. However, none have directly compared traditional angiography to CTA in the derivation. The accuracy of ultrasound velocity criteria is of critical importance, especially when nearly half of patients who underwent CEA in 2003 and 2014 only underwent ultrasound for preoperative imaging. So our first objective was to assess the accuracy of CTA against DSA by testing our hypothesis that there is a high correlation between percent stenosis obtained by CTA to that obtained by DSA, and to update our previous CTA-derived velocity criteria for 50% and 80% stenosis. In order to accomplish this objective, we conducted a retrospective review of patients who underwent ultrasound and CTA, or ultrasound, CTA, and DSA between January 2010 and December 2019. The NASIT equation was used to assess the percent stenosis in each vessel measured on CTA and DSA. Peak systolic and end diastolic velocities of the ICA were obtained from the ultrasound data, as well as the peak systolic velocity of the common carotid artery to calculate the peak systolic velocity ratio. The data was then merged with our previously published de-identified dataset that contains 576 vessels that had an ultrasound and CTA between 2000 and 2009. Data present in the dataset adhere to the same exclusion criteria as our current retrospective review. Receiver operator characteristic curves were generated for PSV, EDV, and PSVR in the analysis of greater than 50% and 80% stenosis. Additionally, Spearman rank coefficient was used to correlate the results obtained from CTA to those obtained from DSA. In total, 1,139 vessels and 636 patients were analyzed. The mean age at the time of ultrasound was 71.1 years old. Of the vessels included in the study, 593 were measured to have 0 to 49% stenosis, 377 were measured to have 50 to 79% stenosis, and 169 were measured to have 80 to 99% stenosis. 124 vessels were included in our subset of patients who had an ultrasound, CTA, and DSA. Inter-rater reliability was high with the Spearman correlation coefficient of 0.96. So in comparison of CTA to DSA, the Spearman correlation coefficient of percent stenosis obtained by CTA compared to percent stenosis obtained by DSA was high at 0.89. The classification of percent stenosis remained fairly consistent with the exception of 6 vessels. Compared to CTA, 5 vessels were classified into a smaller stenosis category when measured with DSA, and 1 vessel was classified into a larger stenosis category. Here we can see the results from our ROC curve analysis of greater than 50% stenosis. The area under the curve for PSV, EDV, and PSVR are all over 0.9, with the results of PSV being the greatest at 0.954. Accuracy and sensitivity were greatest for PSV as well. The ideal velocity criteria determined was 143, 46.2, and 2.15 for PSV, EDV, and PSVR respectively. Here we can see the results from ROC curve analysis of greater than 80% stenosis. Similar to ROC analysis of greater than 50% stenosis, the area under the curve for PSV, EDV, and PSVR are all over 0.9, with the results from PSV being the greatest at 0.939. Accuracy and sensitivity were also greatest for PSV. The ideal velocity criteria determined was 319, 87.2, and 3.49 for PSV, EDV, and PSVR respectively. Our current study is an update to our prior study, adding 563 vessels to the 576 vessels previously analyzed in 2014, nearly doubling our sample size. The update to our dataset resulted in increased velocity criterion for both 50% and 80% stenosis, while preserving a high sensitivity and specificity for each criterion. With a significant reliance on ultrasound as the sole imaging modality for carotid artery stenosis in many institutions, our modern set of criteria could be used to improve the accuracy of patient selection for elective carotid revascularization for stroke risk reduction. In our data analysis, we weighed sensitivity and specificity equally to optimize accuracy. Similar analysis could be done with greater weight on either sensitivity or specificity based on surgeon preferences. In conclusion, we addressed the possibility of inaccuracy of CTA measurements by comparing the results to the traditional gold standard, angiography. Our data demonstrate a high correlation between measurements obtained by CTA to that obtained by DSA. Additionally, our updated criteria demonstrated a high sensitivity and specificity. Thank you.
Thanks so much for that great talk and a nice update to some previously published data. I'm going to kick it off with our first question from Dr. Smets. Did you compare radiologist-reported stenosis to your real stenosis determination? How do our colleagues in radiology do in reporting the percent stenosis?
Thank you, Dr. Hicks, and thank you for that question. I did not include the radiologist reported degree of stenosis in this report. And it was a little inconsistent in terms of what the radiologist reported on the degree of stenosis versus what our measurements were.
Do you have any sense of whether they were measuring them as higher or lower degrees of stenosis?
I think it depended. We focused on using the NASIT equation in order to measure our degree of stenosis. However, the radiologist may have used the ESCT equation. So I noticed some variations depending on the degree.
be interesting to see an inter-rater reliability between a vascular surgeon and a radiologist. I think, when you put this paper together, I think all of us would be pretty interested in that.
Yeah, absolutely. I agree.
Do you have any data from MRIs at all? I think one of the big things is at least personally, I'll get referrals from people patients have had MRI, and it seems to, MRI grossly overestimates the degree of stenosis. And I'm curious if you're able to weigh in on that in this type of analysis.
There weren't many MRIs done, which is why we didn't include MRIs in our study. So I can't really speak to that. I'm sorry.
I think moving forward, I don't know what you guys do at your practice, but are people getting predominantly ultrasounds? Are we seeing a more increase in CTs recently, especially with the advent of TCAR, or how is the practice changing?
Well, especially for asymptomatic patients who are being screened for carotid artery stenosis, ultrasound is the predominant imaging modality. So we do see that more often. However, there are quite a bit of CTAs that are done preoperatively speaking. In terms of TCAR, right in the operating room, the angiography is performed, which is why we were able to do a comparative study between DSA and CTA. That is pretty much due to TCAR, and that's how we had the scans for that study.
I was wondering that because not too many people are doing just general cerebral angiograms anymore, I don't think.
Very true. Very true.
Great. Well, congratulations on some great work, and thank you for joining us tonight.
Wonderful. Thank you so much for having me.